My name is Dr. Faisal Chaudhry. I'm an interventional pain specialist at Florida Orthopaedic Institute. I've been doing interventional pain for about 6 years now. Really, I treat a large variety of conditions. Unfortunately, a lot of people suffer with pain, and many patients have very different pain conditions. So, usually, we're seeing a lot of the bread and butter neck pain, low back pain, but also seeing some very complex cases with nerve injury and chronic nerve damage. Pain really isn't a choice that anyone should have to live with. I want patients to know that, look, there's something out there that's going to help them. The field is changing every day. The technological advancements are amazing. Giving those patients some level of relief and just some quality of life back is really amazing. There's something that we can potentially offer to every patient that comes to us. I think Florida Orthopaedic Institute is really an amazing setup. There's a lot of really world-class surgeons and a whole team of people that are working together to provide patients really good care. It's very important to have pain management on board. It's a unique model in many places. They don't have that. The orthopedic surgeons kind of work independently. But here, having it all in-house, having it together, me being able to refer a patient to my colleague just across the hall to get a consultation. It's a very unique and amazing model that allows us to provide really comprehensive care to patients. On a personal level, I really do enjoy sports, whether that's watching sports, but usually it's playing a variety of sports. I play basketball at least once or twice a week. I really enjoy golf. I have an amazing family. I have 4 beautiful children, an amazing wife as well, who is, very supportive of everything. Just super excited to be part of the Florida Orthopaedic Institute family and continue to give back to the Tampa Bay community.
Welcome, everyone. I'm Amy Bousquet. I'm an arthritis warrior and a member of the Arthritis Foundation's local board. I was diagnosed with juvenile rheumatoid arthritis when I was 13 years old. So I basically have had it my entire life. Tonight's topic is about pain management, something that I can truly relate to and understand. I've always said that I've had a very intimate relationship with pain, unfortunately. I know it well. Through the course of these years, I've had 7 joints replaced, all kinds of medications and treatments. So just to give you like a little bit of background about how I intimately understand what you all are going through if you're here because you're interested in pain management. So let's get to our guest. And before we do, I've got some information to tell you. So based on our Arthritis Foundation's patient-reported outcome assessments, the Live Yes networks, 94% of you living with arthritis in Florida reported an inference of day-to-day pain with different activities. If you haven't already, please take about 10 minutes and contribute to the research at arthritis.org/insights. Have your voice heard and give your information. It's so important to be a part of advocacy. That's how we get these numbers. That's how we decide that this is an issue that people need to hear about. So it's really important that we do that. I'd also like to encourage you to learn more about the Live Yes network, the Arthritis Network puts on, and to get connected with everyone at the foundation. There's so much to offer to the community. You can learn so much more about arthritis.org/Live Yes, or on Facebook at AF Florida. And that's how I became involved. Many, many years ago in my 30s, I had never met anyone with JRA or anyone who had gone through any of the things that I did. And so I reached out one day, and here we are almost 24 years later, still a volunteer with the Arthritis Foundation. So let's get to the reason why we're here this evening. Tonight, we are all excited to learn more about some kind of interventional pain management treatment options for arthritis. I'm pleased to introduce to you our guest speaker, Dr. Chaudhry, with the Florida Orthopaedic Institute in Tampa. Dr. Chaudhry is a double board certified by the American Board of Anesthesiologists with a subspecialty in pain medicine. He specializes in providing comprehensive pain management for a variety of pain conditions. Dr. Chaudhry, thank you for joining us this evening.
Thank you, Amy. Thank you guys so much for having me and for the invitation. I'm honored.
Okay, thank you, Dr. Chaudhry. We have some questions from that were sent in before, so let's go ahead and start with the questions.
Sure.
All right. Okay. So when should a person seek a pain management specialist?
So that's a great question, because I think there's a lot of misinformation about that out there. Unfortunately, pain management sometimes gets a negative reputation because there's a spectrum of different types of pain management specialists out there. But unfortunately, like I said, with this opioid crisis in particular, patients often associate pain management with opioids. And a lot of patients don't want to take opioids. There's a lot of side effects that come along with that. So patients tend to avoid it, thinking, hey, if I go see pain management, that means pain medications. And there's definitely a difference. So what I encourage patients is that, is that pain in, especially where in my field, I'm a lot more interventional based, but even just from a comprehensive perspective, yes, it's a matter of finding the right one, but they want to get pain management involved as early as in that process as you could. If they're seeking care from their primary doctor and they find they're just, they're not getting the results they want, if there's really no change in quality of life, or every time they kind of say, okay, well, let's try this medication or try this medication, and kind of you go through that process. And again, you've probably been there where, that's a normal process. And I do the same with my patients as well. But, my fund of knowledge of the medications or the different options that exist is going to be more broad than the primary doctor who's trying to treat 20 different problems, and again, I don't envy their position at all, because they're trying to manage a lot. But in the scheme of things, sometimes when patients have, heart conditions and high blood pressure and diabetes, the arthritis is a little bit lower on that list of priorities, so in that regards, again, I simply put, it would be, as early as along that process as patients feel necessary, that I think that I may, and again, there's always it's a consultation, if nothing else. You may not see, it may not be what the patient is ready to hear at the time, or whatever that is, but getting another opinion or another set of eyes on the condition is never going to be a bad idea.
Right, that's true, especially another set of eyes. What can be done to treat specifically joint pain?
So, there's obviously there's a spectrum, and that's anywhere from, and a lot of that depends on what type of pain we're talking about, what joint is involved, and what is the underlying condition. When we look at arthritis, for example, there are different forms of arthritis. There are arthritis, unfortunately, like the one, you explained with rheumatoid arthritis. Sorry, juvenile.
Right, but I've lost the J. I'm too old now, so
okay.
It's
right. And rheumatoid arthritis is, actually, a medical condition. Like, it's actually an autoimmune disorder where the body is attacking its own joints. And that's something that's very different than osteoarthritis, which is a degenerative condition. And so part of that does depend on the type of arthritis, the individual needs of the patient. Some patients just want to be able to, take a walk around the block. Some are athletes who want to get back to their, athletic lives, so a lot of that does depend on the needs of the patient. The severity of the condition, necessitates different levels of treatment. Mild arthritis, we tend to categorize things, especially with arthritis, as, mild, moderate, and severe, kind of if we had to put it in 3 different categories just to simplify things. Well, the treatment for mild arthritis will be different than it will be for severe. And so, those are some of the different kind of overall, when we look at it from a broad view, those are the things that we try to narrow down a little bit and then come up with that next step. Is it going to be medications? So kind of taking that a step further, we say, well, something like mild arthritis, is it going to respond to over-the-counter medications? That's usually where most people will start, and then when those stop working, then, okay, we're kind of venturing into prescription strength medications, whether that's, anti-inflammatories, which are usually the first line, because again, part of what we call pathology, part of the problem in the joint is inflammation. Anytime you hear itis, so just as a general, medical term, itis implies inflammation. So, patients that have appendicitis, they have inflammation in the appendix. Arthritis implies inflammation in a joint. And so, anti-inflammatories are very effective. Patients who have autoimmune disorders, they tend to be on steroids. Also, for that very reason, is that to suppress the immune system as an anti-inflammatory, steroids are effective. But we tend not to use that for non-autoimmune arthritis, like just your kind of generalized degenerative arthritis responds well to NSAIDs, which are over-the-counter and prescription anti-inflammatories. NSAIDs specifically refers to non-steroidal anti-inflammatories, and kind of those are the mainstay. And those come in a variety of different forms. There's pills, obviously the primary form. And in that regards, there's obviously like the ones that everyone knows about, ibuprofen, naproxen. But, there's probably a dozen different ones that, most people don't know about. Celebrex is a phenomenal anti-inflammatory. Meloxicam, diclofenac, these are obviously prescription strength. So, someone like myself or a pain management specialist who has a broader repertoire of what medications to use. And because every patient's a little different. Some patients will respond to ibuprofen, patients swear by it. Some love Aleve, some will respond differently to different medications. So sometimes it's a process of saying, well, let's kind of in a structured way go through this and find a different medication that might help you. There's topical anti-inflammatories as well, and then now obviously we're getting into, we're starting to see a lot more usage of medical marijuana, and CBD products. CBD has an anti-inflammatory property to it. So we're starting to see some use of that as well. And then, we often are also using other medications, in particular, things that kind of help modify just how the body perceives pain. What we call neuropathic adjuvant medications, things like gabapentin you hear about, or Lyrica. And again, these are not primarily used for joint issues, but sometimes they work as well. And then obviously end of the road there is for patients that don't respond to anything else. Sometimes they do need narcotic level pain management to have some quality of life. And again, that's not out of the picture. It's just a conversation that is to be had with the doctor saying, these are the risks of the medications and these are the benefits, So that's from a medication side. There's obviously a huge spectrum. And then interventionally, there's an array of different procedures we can do. Something as simple as steroid injections into the joints that are inflamed, be it the knees. That's what we see a lot of. Wear and tear tends to be with bigger joints, the knees, the hips, the shoulders. We tend to see some of the other arthritis, like the rheumatoid in particular, tends to affect smaller joints, the hands and the fingers, the elbows, the toes, so, but sometimes putting a little bit of steroid right in the joint where the inflammation is can be very effective for especially the milder forms. Patients can get 6 months or even a year or sometimes of good relief from those injections. And then again, sometimes that's just the starting point. We have specifically with knee arthritis, we have a lot of other options. In particular, they're what we call viscous supplementation. So these are actually kind of a synthetic gel type that we inject that is been shown to be a benefit as well for the arthritis and is not a steroid. So if we have patients who, steroids are not going to be good for, they're diabetics, we have these options as well. And then further than that, sometimes it's really more advanced where we're working not only just in the joint, but also outside of the joint and trying to, kind of stop some of the nerve signals from the joint going to the brain, because sometimes patients will end up going through the spectrum of treatments and they'll even have surgery and they'll still have pain, and then we got to start thinking kind of really outside the box. And that's where, again, my specialty comes in because, kind of the motto there is, well, if there's a way to stop the pain from getting to your brain, we're going to try to find it, and sometimes it does take very advanced modalities, but anybody who lives in chronic pain knows that it can be very debilitating.
And yeah, debilitating and also mentally draining. And I like the fact that you mentioned that there were different levels, because I feel that on any given day, that's one thing that when I try to explain to other people what arthritis feels like, you'll wake up really, it's really, usually, I don't know, I personally have very tough mornings, and then my day gets a little bit better, and then, a cloud can come by, right? And then, so it's varying degrees on that. And the fact that you mentioned the different levels, I think is really helpful. Because you're right, it depends on the patient and which treatment they need. So do you work in conjunction with other physicians?
Yes, I mean, yeah, especially here at Florida Orthopedic Institute. I mean, we're one big family, one big team. So there's myself, who's part of the pain management side, and then we work very closely with, again, we tend to get arthritis. We tend to think of it only in the joints. Well, the fact is, there's arthritis all over your body. Anywhere there's a joint, you can develop arthritis. I see a lot of spinal arthritis, especially. So a lot of my patients are the ones that have a lot of spinal issues, and so I work very closely with the spine team. In terms of patients that are, maybe, kind of getting to the more severe end of the spectrum of arthritis, whether it be their joints, whether it be the spine, to kind of say, okay, look, we've tried a number of different things. And at this point, maybe it's better for you to see one of my surgical colleagues and they can discuss some surgical options with you, or kind of just introducing what that might mean for patients as well in terms of surgery. So it can kind of get them mentally aware, prepared for that as well. So yeah, I mean, absolutely, it's a team concept. There's very rarely is it just going to be kind of me managing everything, because patients may come in and they may have one knee may be severe, one knee may be mild, and they may just need to have the one knee replaced, and so that the other one can kind of not become severe so soon. And so again, we're working constantly closely with the surgeons to say, okay, if they replace one, and then I manage the other one, or the spine in particular. Patients may need surgery on their neck and their lower back or whatever that may be. So it's a matter of kind of, like I said, working as a team and providing that comprehensive care in all the different aspects.
And are these treatment options covered by insurance?
Yes, absolutely. So, I mean, not all, I think that there's an asterisk there, but the majority of what we offer patients is, and again, I mean, that's a matter of transparency. I will say to patients, I will exhaust just about everything that I can that will be covered by your insurance, because the fact is, vast majority of treatments are the only ones that we see that are not covered typically are things that are still kind of, in those phases where we're still studying them. We're still trying to see, what is the level of efficacy for these on a broad scale. For example, there's a kind of a big, not push, but it's becoming more popular in terms of stem cell treatments, right? Or patients may hear of something called PRP, which is platelet-rich plasma. These kind of a lot of these fall under what we call regenerative medicine, so these are attempts at us taking some of its body's own nutrients and ways to rebuild the joints. Unfortunately, I mean, these are things that have been out for probably 20 plus years now, but we just haven't been able to establish a level of efficacy that compels the insurances to pay for it, but if we talk about standard things such as the medications I was talking about, or the injections, whether it be in the joints, whether it be in and around the back and the spine, those are covered. Those are almost always covered by insurance. Again, we run into just authorization type issues. But the fact is, when you look at in terms of the actual coverage, when it comes around to it, those are covered.
Good. What about pain treatments for folks who have fibromyalgia?
That's obviously
about some pain treatments for fibromyalgia. Sure.
Yeah, I mean, that's a complicated condition,
Right.
and anybody who's suffered from chronic pain or has fibromyalgia knows that if you see 5 different doctors, you're going to get 5 different answers. And I think that's one of those things that even in medicine we struggle with. I think what's been my take on that, and I found what kind of works for me and some of my patients, is to say, look, fibromyalgia is a very complicated condition whereby we find that these are patients that are just more sensitive to pain. They have what we call central hypersensitization, in the sense that ultimately all pain is in your brain. Meaning, not to say, oh, it's all in your head. No, but it actually is all in your head, right? Because your brain has to take all the input that's coming from your periphery and process it, and what's pain and what's not pain. What's just, if I touch myself gently, that's not painful. But for some patients who have severe nerve damage, that can actually be very painful. And so the process there of perceiving pain has now gotten distorted, and that's a lot what we see in fibromyalgia, is that there is this essentially this generalized hypersensitivity to pain. But oftentimes, there are real triggers. So unfortunately, like I said, what happens here, is that a lot of patients do get put under this category of saying, well, it's all in your head per se. So I've found that for me, what works better is to say, well, let's kind of break this down. Let's compartmentalize, let's say, here's the fibromyalgia, which, okay, we're going to work on this. How, we know that physical therapy is very effective. We know that these patients should also be doing, things like along the lines of psychological therapy, cognitive behavioral therapy, meditation, those are mindfulness. These are things that have been proven to be effective. Right. So we try to say, okay, well, this is the fibromyalgia. And even from a medication perspective, there are a number of different meds on the market. There's actually only 3, unfortunately, that are FDA indicated for fibromyalgia, but having a go at those, and those would be Cymbalta for one, Savella is another one, and those are both antidepressants that have really good pain properties to them. And then the third one is Lyrica. Right, so these are the 3 that are kind of FDA approved, but we use other ones that are kind of off label per se, that we know that help as well. So we try to employ some of those medications. Really, one thing there with meds that I would like to kind of point out is that opioids really have been shown to not help patients with fibromyalgia. Long term wise, it tend to cause more problems. They actually make the body even more sensitive to pain. So that's one thing that I have found over the years as well. So I really try to tell my patients that, look, we shouldn't, let's not go that route. And most patients will agree once you kind of explain to them the situation. But when we compartmentalize and we say, well, here's the fibromyalgia, and we're going to put that in this column here, and here's everything else. You might have arthritis in your knee or in your hip or in your back, and you might have all of those. Well, if we can treat those individually, it's going to help everything else, So I tend to find that approach works well with patients, instead of trying to lump it all together and putting in the fibromyalgia category. When I compartmentalize, I think those patients just do better.
So for patients, for example, that have a comorbidity, right, that have fibromyalgia along with rheumatoid arthritis, and let's say they have joint damage that's severe and the joint's already gone, but there's still that pain. So there are treatments for them as well?
Well, again, we would say, well, let's treat that arthritis in that knee as if that's a totally separate problem, because improving that's going to improve the fibromyalgia invariably. But,
Right.
We say, well, let's pick the easy target. And if you can work on that easier target of the two and start to improve that, you'll see some improvement in the overall picture. So, right, we say, well, let's take that joint, or because again, fibromyalgia is a condition where we find that many patients have joint pains. And sometimes there's no real joint damage, for patients will come in and complain of knee pain, and we'll get x-rays and MRIs and everything. And there's really, the knees look great. Or again, the main ones tend to be the bigger joints, the shoulders, the knees, the hips, as well as back pain. A lot of patients with fibromyalgia have neck pain issues and lower back. These are some of what we call tender points. These are things that we look for on exam to say, okay, if there's this pattern of generalized pain, both kind of above the waist and below the waist, and tends to be pain that kind of moves around a lot. Some days something hurts and some days something else hurts, and there's not actually a lot of tissue damage that we see on our diagnostic testing. That's how we tend to kind of say, okay, this might be more of a fibromyalgia problem. But even if there is some tissue damage or something to work with within those areas, if we treat that kind of individually, like I said, that tends to work well.
All right. So we have some viewers who are interested in knowing about nerve blocks. So how do nerve blocks work?
So that's a great question, because that's what I do a lot of. So essentially, what it comes down to fundamentally is, our nerves in our body act as kind of wires in a circuit, and they connect the brain to kind of wherever that input is coming from. So, if I pinch my finger, all right, well, that signal's got to make it from there to my brain for me to feel it. And it does that through nerves, obviously. And it does that through predominantly very, 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 very small nerves that we can't actually even block or find. But there are big nerves. There are nerves that we can actually identify, specifically when it comes to some of the joints, where there's bigger nerves that innervate the joints, innervate meaning that the nerve takes the pain from that joint to your brain. And that's true for, almost every kind of big place in our body, the knees or the hips or the shoulders or the spine. There are nerves at various points that kind of transmit those signals. So the concept there is to say, well, again, now there may be an issue where there's tissue damage, there's arthritis that's severe, or in many cases, there's arthritis that has already been fixed. Patients may have a knee replacement and still have pain. So, well, I mean, it's a theoretically it's a metal joint. It shouldn't have any issue, but the nerves are still there. So in that along those lines, a mantra, to some degree, is to say, look, if there's a nerve that we can find and we can block the nerve, well, we can find a different way to maybe stop that pain from getting to your brain. And that's how nerve blocks work, is that we identify the nerves, whether it be with different modalities of imaging. Oftentimes if they're peripheral nerves, kind of smaller nerves, we're using ultrasound to find them, or if we kind of have a general idea where they are, we can even do it under x-ray, but some kind of image guidance. And sometimes it's blind as well. We kind of have a very good sense of where some of the nerves are in the body, and we can target them that way. And oftentimes we're using just maybe local anesthetic around the nerve. So local anesthetics, things like Novocaine. If you go to your dentist, what they do is they first just numb your tooth, and they do a tooth, basically a nerve block on your tooth. The nerves, for your tooth kind of run right underneath your tooth in the gum line, and that's where you often find the dentist will just inject a little bit of Novocaine and localizes those nerves going to the tooth so they can work on the tooth without you feeling too much pain. And that wears away obviously an hour or two later. So we have some medications that work longer than that. But oftentimes the concept behind a nerve block is to say, well, let's identify, is this target really the source of the pain? If I say to you, look, I think this pain's coming from this joint, and we block the nerve and you don't feel a lot better, and we're sure we blocked it, then we got to start thinking, is there something else going on? That's one way also where nerve blocks can be very helpful, is they often are employed as a diagnostic process. And this is especially true when I'm doing a lot of blocks around the spine in particular, is they're often part of a diagnostic process we're trying to go through to really figure out, where's this pain coming from? So again, at a fundamental level, we're essentially injecting medications to numb the nerves, to stop, and that when we say numb, what that's doing essentially is, we're stopping nerve conduction. So nerves are like wires where the signal has to make it through the wire to the other end. So if you have ways to stop that from happening, and that's what the medication such as Novocaine is one that's used commonly, or the other one I use commonly is called bupivacaine, and it's a longer acting version, but it essentially works on those nerves to stop nerve conduction, so you no longer kind of feel that area that hurts.
And typically, how long do those last? Does it depend on the area? Or?
Yes, I mean, it's very dependent on the area. And again, I mean, classically, just a nerve block implies that it's very short-lived, and it's really more diagnostic than anything else. But where that kind of goes by extension is that oftentimes if we're able to identify a nerve in a certain area, then we're able to block it and get good relief, even temporarily. And there's a possibility for us to then do something called an ablation of the nerve, where we can do something where we actually kind of, layman's terms, sometimes we call it burning the nerve. Anybody who has kind of spinal pain issues might know this, and they might have experienced this. But that's a procedure whereby we then can take some specialized equipment to more or less short that circuit. Like I said, the wire that's going through, well, if we find a way to kind of stop that transmission for a longer period of time, that can be very effective for these areas that are painful. So again, ablation is one term. Radiofrequency is another term we use for that. Neurotomy, which kind of means to destroy the nerve more or less. Burning the nerve is another term. So these are just different terms that, depending on the doctor who's kind of presenting it, patients might hear.
Interesting. What about joint injections, like actual joint injections? How often can you have those?
There's a lot of variability, that exists with those. Typically, the standard is about 6 months. If we're talking about something like a steroid injection in a knee, we really do want to space that out by about 6 months. Part of that has to do with the steroid effect on the body itself. Part of it has to do with, the steroid effect on the joint. We know that kind of long term, kind of repeatedly injecting the joints, isn't the best for the joint either. We're putting a foreign thing in there, that joint is not normally there. So we really do try to get 6 months out of the injections, especially if they're in a joint. But there's exceptional cases. If we have patients that we know that, hey, we did one, and maybe 3 months later the pain's starting to come back, and we know that if we do a second one at that point, that patient might actually get a year of relief. Because it kind of compounds on it. If there's a kind of one model I give patients is, if there's this much inflammation to start and we kind of knock it down, well, if we stop there, it kind of works its way back up. So sometimes while it's down, we want to hit it a second time.
Yeah.
So sometimes we'll use that concept as well to say, okay, look, it's been a shorter time than we had hoped, but maybe if we do it now again, we might get that long relief that we're looking for. And so that's one. If we were to look at strictly insurance guidelines with some of these things, in particular the joint injections, especially those gel shots I had talked about, that's typically 6 months. The insurance companies want you to wait 6 months in between each one. Because that's that, when we look at the what we call the data, kind of like, hey, on average, how many, that's kind of the relief that most patients will get. Some patients get, way better, some get a little less, and so that's where kind of a comprehensive plan that says, okay, if you get an injection that helps 50-60% for 6 months, or vice versa, where you do it and it helps maybe 80% for 3 months, well, the other 3 months before you can get your next one, you kind of got to come up with a good plan to keep that pain at bay. And so that's why it's a comprehensive approach. It's rarely ever just kind of one thing will take care of everything. But
And then
so,
after, I'm sorry, I was going to say, then after you've had various injections, is there a point in time where the joint, you just can no longer inject into the joint?
Again, part of that is that, we know that degenerative process is going to continue, potentially even worsen over time, and, we have to make a call at some point to say, look, if it's kind of bone on bone arthritis, I'll tell patients, look, we can do this. I'm not promising you anything, but if we do it and it doesn't help, we're not going to do it again in 6 months, right? We did it 6 months ago and it didn't do anything for you. So, we look at various things in that regards. If there's any like real hard objective endpoint, honestly, not really. Because again, at the end of the day, it's about a conversation with the patients of saying, these are the risks, these are the benefits, and as long as we're doing things within guidelines, where, we're not doing them every month the patient comes in, but if we're spacing them out appropriately and we're keeping an eye on the bigger picture of saying, hey, for my diabetic patient, I'm not going to give them 10 steroid shots a year. They're going to maybe get 2 or 3. And then we got to say, look, we just got to make the most of what we got and let's try something else in the other 3 months, So there's no real hard stop per se, other than the fact that, if they don't work, we do say, hey, look, maybe this is not something we should keep doing. Or if we're not getting the relief that we would hope to get, those are good endpoints of kind of saying, maybe we got to think of something else.
So if someone wants to come see you, do they need to get a referral from a physician?
That again largely depends on the insurance. There are certain insurances where yes, that is a requirement. Most of the HMO plans, so if patients are familiar with their insurance in particular, and they have something called an HMO plan, which is a kind of a very small, the insurance company decides that these are the doctors within our small network, and you can only see people within that network. Well, then those ones often require a referral to a specialist. Most PPO plans don't require that. Medicare does not require any kind of referral process. So again, a lot of that is really dependent on the insurance. We always just encourage patients, they'll call the scheduling line, they'll talk about your insurance, and they'll let you know, and oftentimes getting the referral even is not the patient's responsibility. It falls on the group oftentimes. Sometimes, yes, we will ask the patient if we're having a hard time, but more or less, usually there's a whole department that's designated to getting the referrals and to getting all that kind of authorization paperwork that needs to happen. There's a whole army behind the scenes, because that's really what it takes to fight the insurance companies sometimes. But that's what it is. There's a whole army behind the scenes that their job is to make sure that, you know, when patients make it to the office, everything's kind of squared away.
Okay, yeah. And as a patient, we appreciate that army.
Yeah. Oh
You
yeah.
know, because
Oh, as
sometimes
a physician,
half
I
the,
appreciate it even more. Trust me.
yeah, yeah. Half the battle is being your own advocate, you know, fighting. You really learn to fight for yourself. But so having that army is so helpful. So
Yeah. And at Florida Orthopedics, again, there's an army. There literally is an army of
that's
people.
wonderful.
Yeah. So
So,
they're,
okay, the patient's gone through that. They've gone through the army, and here they are, and they're your first. What can they expect at their first appointment?
so that's a great question. For one, I mean, you know, we tend to tell patients, you know, if there's any kind of pertinent records that they might have, just bring them, you know, because, you know, oftentimes they'll might have had some testing done that we then may not need to repeat. Or a lot of times, you know, again, if they've tried certain things already, you know, if they've had steroid injections that they haven't had the gel shots, or they've had, you know, this, they've tried this medication and not this one, you know, so just having some old records definitely helps. You know, and the more kind of more organized those are, it really is very helpful for the physicians to kind of weed through that in a quicker way as we're talking to patients often, and just trying to get a really good sense. You know, in my office, typically, well, patients will come in and they'll check in, and there'll be a kind of a series of questions, a questionnaire more or less, that they'll fill out. Now, ours are electronic on an iPad, for example, just to get a sense of, you know, what is the pain, where does it hurt, what's it feel like. And these are just, some of these questions are actually more just, you know, kind of, you know, run of the mill routine questions we ask patients anyway, because it actually, you know, it's very helpful. You know, there's a difference between pain that's kind of sharp and stabbing versus pain that's dull and aching, you know, or pain that's burning, or right. I mean, these kind of, these little clues can tell me different things sometimes. And so patients will fill out a questionnaire that'll ask them a series of questions along those lines of, you know, kind of where it hurts, what's it feel like, what makes it worse, what makes it better, you know, what do you take at home, what have you tried before, you know, that's kind of the general questions there. And then if they haven't had any imaging at all, you know, we have facilities on hand where we're able to do x-rays, at least, you know, usually, you know, on any patient that comes in. If they haven't had any imaging, then we'll usually send them for x-rays before they're seen, so that when we see them, and we're able to kind of look at the, you know, go over their pictures together. That's very helpful. I think a lot of patients find that very helpful, is to, you know, see their own, see the spine or see the joints or whatever it is we're talking about, you know. So we have those x-rays beforehand, so we can kind of go through those together. And then, you know, like I said, I mean, a lot of times even the patients will fill out the paperwork, we'll often ask the patients kind of, you know, like just overall, you know, what is it that brings them in, you know, where does it hurt? And oftentimes, you know, these patients have multiple pain issues, you know. I mean, it's rare you're just going to have arthritis in one joint, right? It's going to be maybe in both joints, or it's going to be in the knees and in the hips, or it's going to be in the knees and the back. So trying to just weed down, hey, what is it, you know, what's really the main problem? What are some of the secondary problems? And then from there, oftentimes, like I said, a physical exam is a big part of it, you know. So, you know, and in that regards, there's a lot of clues that we can pick up. So the patient, you know, should expect to be examined. So oftentimes we say, hey, just wear clothing that's kind of conducive to having a physical exam. You know, if you have knee pain and you're coming to see me, well, skinny jeans might not be the best idea that day, because we're not going to be able to get them up over the knees, you know. So kind of loose clothing is always helpful to kind of access the areas where it hurts. And oftentimes, like I said, in that exam, we're picking up things as well, you know, kind of what hurts and what doesn't hurt. And then from there, you know, like I said, oftentimes I'll review whatever pertinent imaging I have with the patient, and say, here, look, these are your knees, these are your hips, whatever it is, this is what we're looking at. And you can see kind of how this looks, right? And here's a normal picture, and this is yours. And it becomes, you know, very clear to the patients what's going on. And then we'll talk about a plan, and a comprehensive plan. And I tend to kind of have a few different aspects to my plan that I like to address every time, which is, you know, what are we doing with your medications? Are we changing them? Are we leaving them? Are we trying something new? You know, have we discussed injections? If we have, well, what have we done already? What's kind of in our next step? You know, are you doing physical therapy, or are you exercising at home? What kind of routine are you keeping? You know, and then, or hey, look, you know, maybe it's time for you to see someone else, or, you know, do I need to put a referral in? Diagnostics, do we need to get any new tests done? So, you know, I'll tend to kind of hit on some of these major points kind of in a very almost sequential manner, That then, so I make sure on my end, most of this is just because, I like to make sure I'm not missing anything, but I think it helps kind of doing it in a real systemized manner, so patients kind of understand what we're doing head to toe. Um,
Anything else that you'll do on that first? I mean, that's very comprehensive. I'm sure that takes a while.
It does. It does. I mean, those first visits we typically will block out, obviously a little longer than just a
Right.
follow-up visit. But no, I mean, that's the extent of it. I mean, I think, there's really not much else that we're going to be able to do during that first visit, but a lot of patient education. A lot of it is, these are your options. Sometimes patients are just coming in to get an opinion, and we say, look, this is what the problem is. These are all your options. Think about it. Obviously not every patient that comes in is ready for an injection the same day. So, but I like to say here, look, these are some of the different things we do. These are some options. Oftentimes, if I have some handouts as well already prepared, we'll give those to patients so they kind of can review the material on their own, and then when they come back the second time, we can have a further conversation with it. Sometimes they're ready. Sometimes they still have to think about it. But to me, it's just presenting that patient with, kind of a lot of the different options that exist for them. And then we kind of weed through those.
And that's really important because knowledge is power. So once you have, especially when you have an illness like this, that you feel like you're losing power over your body, and you provide a patient with that information, and then they can go and read about it, research, look it up, and come back, ready for.
Oh yeah, it's great. I mean, patients are, like you said, being advocates for yourself is huge. And so patients will come back and ask me things. They'll say, hey, what do you bet? What about this? We came across this. And that's what I find the most about is that, because it's constantly keeping me learning about maybe something new that's out there. So, I find that educating the patients about their condition really kind of helps them as well understand things, and helps them maybe look further to say, what else can I do?
And in the last 40 years with this illness, just from my own personal experience, I've noticed such strides in research. I mean, just to give you kind of an idea, when I was 13 years old, course of treatment was aspirin. So I used to take 21 aspirins. This is back in 1976. They injected my joints, but throughout these last 40 years, I've seen I've witnessed, I've undergone so many treatments. So kind of to wrap up tonight, can you tell us what you see on the horizon as far as in the world of pain management? Do you see new medications, treatments, anything?
Oh, there's a lot. There's a ton, I mean, and I think that, again, if we kind of break it down, typically we'll say, well, just from a medication end, there's always something new coming along the lines. And in terms of, just like I said, I mean, a lot of that process of medications is just, stopping the signals from getting to your brain, kind of, how do we modulate those signals from getting to the brain, and kind of moving away from opioids, to non-opioid medications, and things that maybe work at a much more physiological level, and genetics. We know genetics plays a big role in it. Again, with juvenile arthritis, this. I mean, there's a part of that is genetic, and so genetics play a role in arthritis. A lot of our patients, they'll say, yeah, there's a family history of back problems or arthritis. So kind of some of those novel, what we call gene targets, and kind of finding some of the genetic profiles that might help us. And obviously, these are things that are really like on the horizon, but pretty far at this point, from a genetic end. But so newer medications are constantly coming out, whether it's, I mean, just whether we're along the lines of anti-inflammatories and or just pain medications per se. Again, and I think a lot of from the injection side, we had briefly touched on regenerative medicine, I mean, and we're compiling a lot more data and showing that it really can help a lot of people, and so unfortunately right now it's not covered by insurance, so it makes it cost prohibitive. If it's $500 or $1,000 for an injection is a lot of money, so some patients can't afford that. But when it becomes more kind of mainstream and is something that insurances are willing to cover, that'll open up, I think, a whole nother option for those patients. Surgically, there's a lot of advances as well. I mean, we're doing outpatient knee surgeries now, so again, 10, 20 years ago.
Outpatient, wait, did I hear that correctly?
Oh,
I'm
yeah.
processing that. Outpatient knee surgeries?
Oh yeah, I mean, we do them at our surgery center right here. I mean, some of the
Wow.
docs are doing outpatient knee replacements, because they've just gotten so good they're so efficient at the procedure. Controlling the pain is so much better now. Just, so many, and so patients are not in the hospital for 3 days and prone to, more infections and all the things that
Right.
come along with that. And, and so from the surgical end, there's a lot of advances. And then again, in my field in particular, from an interventional pain side, there's a lot of stuff on the horizon where, ultimately at the end of the day, again, patients who have a lot of chronic pain issues that are non-responsive to anything, if we can find ways to stop those signals from getting to the brain, and sometimes we have to do that at the level of the spine itself. So in particular, kind of one of the fields that's really growing rapidly is called neuromodulation, where these are kind of small, like implanted devices, and sometimes they're just a kind of small implanted stimulators right around the joints where the pain is. Sometimes we're targeting the level of the spine and the spinal cord where all the signals are coming together and going up to your brain. Well, we're just finding ways to stop it there as well. And again, these have been out for a long time, but we're really refining these treatments to treat very isolated, areas in particular. So neuromodulation from an interventional pain side is huge. It's kind of really where we would say that kind of the next frontier is in terms of that.
Well, thank you. Thank you so much for giving us hope. I think that's really important. It's always been my favorite word. I say I can never lose hope. And so by letting us know what's coming, what's the future, you've given us some patience, some hope. So we thank you for that. This has been a very interesting conversation. Is there anything else that you'd like to say to the people watching, or?
But no, I would just, what you kind of echoed there is that, look, there are options out there, just kind of one of my mantras, if you will. It might sound a little cheesy, right? Is, that living in pain really isn't an option you should have to make. Some patients choose to do that, and just because they don't know better, and so, seeking the advice of a pain specialist and saying just, hey, what are my options, or just even understanding the problem a little bit better is very helpful. But knowing that there are a lot of options that are out there that you probably haven't tried if you haven't seen the right specialist. So, kind of come, it's a level of comfort as well. But I think most patients will find that, opening that horizon essentially can be very, very helpful. So, think about that, think about where you are and kind of what it is you're looking to do. And like I said, if nothing else, it's just a consultation that you might not get much out of, or it might really change your life more or less, and so in that regards, like I said, I mean, I encourage patients to look into it, consider pain management, because there's a lot we can do.
Right. And we shouldn't have to live in pain. There's no need for that. And so
that's kind of what, that's what, if I had to sum it up, I'd say, look, don't just choose to live in pain.
No.
There's,
it's a whole holistic, it brings you down. And so, I know that there are moments when my pain's relieved, that all of a sudden the sun comes out, and you see the world differently. And so you give that gift. So that's wonderful. So I thank you for that. So this has been a wonderful discussion. I really enjoyed it. I've learned a lot.
I enjoyed it. Great questions.
Oh, thank you. So thank you to everyone who's joined us this evening. And thank you to Dr. Chaudhry for taking your time to be with us. To anyone watching, if you want to learn more, please visit our floridaortho.com for Florida Orthopedic. And of course, the Arthritis Foundation is arthritis.org. So good night, everyone. I hope you've enjoyed this. I certainly have.
Thank you.
So
Good
much.
night.
Good night.